So we worked very hard to identify what were the most important things that people needed to know. And for each chapter, we start off with key messages for each of those groups. So it was an excellent opportunity for us to think through what really matters. And if we had limited space and time, what would we focus on for those three distinct groups? Uh, if I move on to the second bullet point, you'll see what we were surprised to come to as very high numbers of exhibits. So when we were trying to describe the Ontario health system, we quickly realized that to do justice to it, given how complex the system is, it took a lot of tables and figures. I think the ones that we find the most helpful are what we call the Sector 4P figures, where we show any given part of the health system at the intersection across the 6 sectors, which I'll describe shortly, and then the 4 Ps, which for us are policies, programs, places, and people. And I'm going to give you an example of the Sector 4 people later in the presentation. So the book is going to be available soon. We're not doing this to make money. We're simply trying to cover our costs by making it available through what for us was the most efficient distribution mechanism, Amazon. But individual chapters will be available at the same time as it's made available for purchase on Amazon, but in this case for free through the McMaster Health Forum website. So if, as I'm going through the presentation, if you conclude, gee, I'd really like to read more about primary care in Ontario, or I'd like to see how they use these Sector 4P diagrams, then you can easily download for free any of the chapters. So effectively, the entire book is available for free if you want to download it, but if you want it looking like a proper book, you can purchase it through Amazon. So if I now move on to the next slide. I guess this slide is more of a plea to those of you who are intrigued enough by the presentation today to actually want to read one or more of the chapters and perhaps the full book. This will be a regularly updated book and set of chapters, and this is our first edition of it. We anticipate that we'll revise this version sometime late in 2017, so roughly a year from now, with the hope of getting out a second edition sometime early in 2018. But when you read it, the 5 questions that we asked the 41 reviewers of the book and that we would ask you as readers to keep in mind are, do the key messages highlight what each of those 3 groups need to know? So whether you're coming at this as a patient, as a professional, or a policymaker, did we get the forest clearly described without getting too bogged down in the trees? And that brings me to the second point. We got the big picture right. The third, though, is more about the trees. Did we get any of the details wrong? Across the 41 reviewers of the book, there were only 2 subsections of the entire book, subsections of a single chapter, where we got a few things wrong. We've corrected those. But inevitably, in a system as complex as Ontario's health system, there's still some details there that might need correction, so we welcome your feedback on that. Fourth, and very importantly for us at the McMaster Health Forum, do we present the material in a fair and balanced way? So our intent is not to demonize anyone in the system, to point out significant shortfalls that should have been rectified a long time ago. It's to as honestly and accurately as we can describe how the system works. And then finally, do we use language that is appropriate for an audience comprised of those distinct groups? You'll see that we have the word engaged before, especially citizens. So we're not saying that this is going to be the perfect book for people that aren't really engaged in healthcare related issues, but we do think for those folks who sit on patient and family councils, who play a particularly significant role as caregivers, who really have reason to want to understand how the system works, then we hope this is the right book for them. But if you have feedback on for us about how to improve it for the next round, we'd warmly welcome it. So if I now move on from context to the key messages, we in fact have 11 chapters in the book, as well as a preface and a conclusion. But I'm going to focus here on the 10 substantive chapters. So I have 4 key messages related to what we've called the building blocks. So some of you will be aware that the World Health Organization uses the term building blocks of health systems. They have different categories than we use. We tried unsuccessfully to use the WHO building blocks when we were coding systematic reviews for inclusion in our database called Health Systems Evidence, and found that we needed a much more nuanced 3-level taxonomy than the relatively simplistic 1-level categorization scheme that WHO uses. So we talk first about governance arrangements, which in plain language means who can make what decisions in the system. Financial arrangements, which is about how money flows. And then we talk about 2 types of delivery arrangements, both infrastructure and the workforce in the system. Then we move on to using the building blocks to provide care. And we begin by reviewing care by sector. So most health systems distinguish among 6 sectors, and that's how we've done things here. Home and community care, primary care, specialty care, which includes hospitals, but also other settings, rehabilitation care, long-term care, and then finally public health. We also then discuss care for select conditions. Of course, we could have a list of 20, 40, 60, 80 conditions or groupings of conditions that we could have focused on. We focused on the ones in Ontario that are particularly salient right now at the top of the policy agenda, and or parts of the system that are in fact treated almost as separate subsystems of care. So mental health and addictions, work-related injuries and diseases, cancer, and then the one that is a bit different but a current policy priority, end of life. Then I'll move on to care using select treatments. Again, we could have focused on many, and if you have advice about which ones need to be in the next edition of the book, we'd warmly welcome them. For this edition, we focused on prescription drugs, on complementary and alternative therapies, and on dental services, 3 areas that to a great extent in Ontario are outside the publicly financed system and paid for in most circumstances privately. And then finally, we move on to care for select populations. In this case, we focused only on a single grouping of people, and it's Indigenous peoples. They've done that because now this is a group of individuals where the Government of Canada, the provincial government, and many stakeholder organizations have committed to do much better than has been done in the past in terms of a nation-to-nation relationship with Indigenous peoples and efforts to right past wrongs and to provide a much better health system that meets the needs of Indigenous peoples. So for this edition of the book, we focused on only one population. But again, we welcome your feedback on for future editions about other populations we might want to include. And then finally, I'll talk about change in progress. Many reforms have been made in Ontario. We focus in the book on reforms over the last 15 years, and we also talk about assessments of the system, whether those have been done by the Auditor General or by other evaluators in the system, and we use the triple aim objective to talk about that. So that's the overview. And so now what I'm going to do is jump into the key messages. Top 10 messages, I should say. I have to admit I've cheated a little bit in the sense that I do have 10 messages, but I also have typically before that message an organizing framework that we have used for that particular chapter. And I also have a second message for those of you who want to know a little bit. So I'm going to start with governance arrangements, which we have worked through in the sense of talking about policy authority, organizational authority, commercial authority, and professional authority. And then we also talk about citizen and stakeholder involvement in the system. So if I could only tell you one thing about governance arrangements in the Ontario health system, what I would emphasize is that the Government of Ontario, who has constitutional authority for most aspects of healthcare, makes decisions in some areas and delegates decisions in others. So an example of the former would be that it makes decisions about who's eligible for what prescription drugs are part of the Ontario Drug Benefit Program, but an example of delegation would be to the province's local health integration networks about planning, integrating, and to some extent funding many types of care. Now, LHIN's much less discretion about funding than many people think, but nevertheless it does play that role as a funder. But they also decision-making authority to regulatory colleges, to government agencies, for a range of different issues. So if I only tell you one thing about governance, I would focus on the policy authority piece and the existence of these delegated decisions. I'll just flag for you that I've given as a second message something that relates to organizational priorities. And here in Ontario, we have what some people call a public payment private delivery bargain, which means that there are many private organizations delivering care who have a fair amount of discretion in many aspects of how they operate. So that's my kind of backup to my first top 10. If I now move on to financial arrangements, so how money flows in the system. In the book, we make a distinction across 5 points. So financing the system. So where does money come from to pay for the system? That's the focus of the second of my top 10 messages. Funding organizations. How do we pay places like hospitals? Remunerating providers. How do we pay people like physicians? Purchasing products and services. How do we decide, for example, which technologies like drugs will enter the system? And then finally, incentivizing consumers. How do we create incentives for patients or citizens to either use or not use services? If I had to pick a single message about financial arrangements, it would be that first bullet point. We spend now nearly $6,000 on average per Ontarian on health. That comes largely from taxes paid to government, about 2/3. Most of that money goes for free at the point of use, hospital-based and physician-provided care. And the other third, which is a very significant amount of money, comes from private sources, both insurance plans and out-of-pocket charges. And most of that, a lot of that money is spent on prescription drugs. And in fact, we have among the highest per capita prescription drug expenditures in the world. And as you'll see here, a big chunk of that is paid for privately. The second bullet there is a backup, is about remunerating providers, in this case primarily physicians, but I also mentioned some other providers. I'm just going to show you a quick example of the typing in the book. So on slide 13, you'll see a figure that if you read it counterclockwise, starting in the top left corner, it begins with, as you move down, financing the system, citizens paying taxes, paying for goods and services, paying premiums, and so on, which then gives us the money that is pooled to pay for healthcare in the system. That money then funds organizations and remunerates both professionals and workers, with that money flowing partly through the Ontario Health Insurance Plan for doctors, partly through local health integration networks for hospitals, among others, partly through the Workplace Safety and Insurance Board for people who have been injured or have work-related diseases. And then providers end up providing programs, services, and drugs back to citizens. So there's more detail there that I could speak to, but suffice it to say that this is an organizing framework that we use in this chapter to help people understand how money flows through the system. So if I now move on to my third of the top 10 messages, this one is about infrastructure. And we mean by infrastructure both the places where care is delivered, the clinics, the hospitals, the long-term care homes, but we also mean supports for care. Some examples would be we have a teletriage system in Ontario called Telehealth Ontario that we can phone for advice. We have a video conferencing system that allows for clinical care to be provided at a distance through the Ontario Telemedicine Network. And we also have electronic health records. Ontario is known for being behind many other jurisdictions internationally in the use of electronic health records, but things are improving relatively rapidly on that front finally. You'll see my second message here has to do with capacity planning. I don't have a message about capital spending, but suffice it to say that we do capacity planning for some parts of the system. Hospitals would be the obvious example, but we do not do capacity planning, largely because, again, of this public payment private delivery bargain, where we leave it to those private deliverers of care to do their own capacity planning. And I give you some examples here of agencies, teams, and independent health facilities. If I now move on to message 4 is about the workforce. And so the organizing framework we use for this part of the book is supply density and distribution of that workforce. We talk then about the regulated health professionals and the unregulated health workers in the system and the policy levers that can improve the supply, distribution, and performance of health workers. If I only had one message related to the workforce, it would be that we now have 28 regulated health professions. They're regulated by 26 regulatory colleges, and we have many categories of unregulated health workers. The prototypical example would be personal support workers, but I could list 8 or 10 others, like paramedics, for example. But almost all of the ranks of these professions and workers have increased in number over the past decade, both in absolute number and in their density for every 100,000 Ontarians. Doesn't mean that we have solved the distribution problem, that we don't still have many people who have difficulty accessing care. And you'll see my second bullet has to do with accessing physicians, but we have made significant strides in the last. So if I now move on to message 5. So message 5 now is where we start to make use of the building blocks to provide different types of care. And this is where we then talk about those 6 sectors that I mentioned before: home and community care, primary care, specialty care, which means hospitals and other things, rehab care, long-term care, and then public health. So again, if I had one message, the 5th of my top 10 messages would be that 5 of the system's 6 sectors have a key player. So community care access centers for home and community care, primary care teams or family physicians for primary care, hospitals for acute specialty care, long-term care homes, obviously in that sector, and local public health agencies, of which there are, I've now blanked out, I should know this, 26 or 36, I think 36 across the province. We began the book thinking they were called public health units. That was corrected for us. Units are the geographical unit that a public health agency covers. So we have public health agencies across the province whose borders are not coterminous with the LHINs that was originally designed to be addressed through the Patients First Act, but in the final version that was passed, that was not addressed. You'll see my backup point is about rehab, the one sector that is a bit different in 2 respects, which I describe in the second bullet. So if I now move on to the sixth area, I'm sorry for my voice and the periodic coughing. The 6th area is care for select conditions. So I mentioned before, we picked 4 for this first edition of the book. All the focus of significant government attention now and or very uniquely treated almost subsystems of care in our health system. So again, if I had one thing to tell you about care for select conditions with these 4 examples, it would be that for 3 of them, addictions, work-related injuries and disease, and cancer, they operate to varying degrees as separate subsystems of care. And the one that is perhaps the most dramatically fully parallel subsystem is cancer. And cancer care is overseen by an arm's-length provincial agency, Cancer Care Ontario, and 14 regional cancer centres. But for various reasons, we treat cancer very, very differently. It's almost a separate, completely separate subsystem of care. Of course, it intersects with home and community care, primary care, and so on, but in ways that are unlike almost any other condition, this is an area that's treated very, very differently. You'll see my backup point, if I was allowed 20 messages instead of 10, has to do with end-of-life care, or end-of-life, where things are increasingly promising. Lots of exciting new developments. Some regions, like the Champlain region around Ottawa, increasingly providing much more standardized palliative care in Ontario. We can't say that we have great consistency in what can be expected at end of life from one community or region to the next, but the government has introduced networks and a provincial network that will actually serve to increase that consistency over time. So we're taking steps to address that issue. If I now move on to message 7, 7 out of 10, this now brings me into care using select treatments. And I mentioned before, Here, for the purposes of this first edition, we focused on 3 broad categories of treatments. Those 3, prescription and over-the-counter drugs, complementary and alternative therapies, and dental services of the expenditures on complementary and alternative therapies, and dental services happen on the private side through payments from private insurers or out-of-pocket payments from individuals. In my second bullet, as a backup point, I elaborate a little bit on prescription drugs. So you're certainly covered if you're receiving home care, if you're admitted to a hospital, if you're in a long-term care home. You may be covered if you meet the eligibility criteria for the Ontario Drug Benefit Program or some of the province's other drug or disease-specific programs, but many Ontarians have limited or no coverage for their prescription drugs. So a real differentiator, not compared so much to other provinces, but certainly compared to other health systems. If I now move on to message 8, care for Indigenous peoples, and I earlier commented on what led us to highlight this particular group. Indigenous peoples have the same coverage and benefits as other citizens in the province. While that sounds very promising, geographic location, many other factors, though, can make accessing these programs and services exceptionally difficult. So while they, in theory, have the same coverages and benefits as other citizens, in reality, their access is often severely hampered. They can, though, also sometimes access dedicated facilities. An example would be Aboriginal Health Access Centres, dedicated programs. I've given you an example here, dedicated providers, and dedicated cultural and linguistic supports. You'll see my second bullet, if I was allowed 20 top 10, if I was allowed a top 20, it would be, while the health status of Indigenous peoples tend to be worse than the non-Indigenous populations, people are very much trying to take a positive, strengths-based approach to health improvement, and very much one rooted in Indigenous ways of knowing, Indigenous governance, and Indigenous control, which is likely going to be key moving forward in partnership with Indigenous peoples. If I now move to reform, so 9 out of 10, the last decade and a half, so I mentioned we focused on reforms made in the last 15 years. It's been a time of many reforms for those who are working in the system. Depending on the part of the system you work in, it might feel like a reform has happened again and again and again. Other people working in the system might feel somewhat untouched by these reforms. When we look back at how they relate to political events, we see that they're often initiated after key electoral events, the 2003 election being particularly noticeable for the number of relatively dramatic reforms that happened relatively quickly after that election. And these reforms have started to create a more integrated system. So 15 years ago, people probably would have pushed back very hard on a book called Ontario's Health System, arguing that in fact we didn't have a system per se. More and more, I think, while people might say we're certainly not there yet, we're increasingly taking steps toward trying to make sure that the system functions in a more integrated way. Some of you will know that last week a new piece of legislation, the Patients First Act, was passed. It modified either 19 or 20 existing acts, and one of the many things that it will do is expand the role of LHINs in planning and integrating primary care and home and community care. And so there now is the greater potential for those sectors to be much more fully integrated into the core system to provide more seamless patient-oriented care. And finally, on to my final top 10 assessments. Evaluations of whether the health system is achieving the triple aim, and by triple aim I mean improving the patient experience, improving population health, and keeping per capita costs manageable. Our existing evaluations don't provide a balanced picture of performance across sectors. We have much more focus on acute specialty care. Doesn't provide a balanced picture across conditions. We have much richer data and reporting about cancer care than care for many other conditions. not balanced across treatments, much more focus on prescription drugs than others, and also not particularly well balanced across populations with limited emphasis on marginalized groups. So we have made major strides in Ontario in terms of evaluations, but still lots of room for improvement in terms of a balanced picture of whether and how quickly we are moving towards achieving the triple aim. You'll see an additional bullet there about some of the unequal distribution of progress across regions and across domains where issues like we single out here per capita drug spending, which, as I flagged before, among the highest in the world, continues to be a challenge. We spend roughly $800 for every single Ontarian on average, which is exceptionally high and higher than almost all of our typical comparators. And it remains an issue that we seem to have difficulty getting under control. So that's my top 10 for Ontario, but I promised some insights for other systems. I think probably the most important thing that people from other systems can take away from the book are the frameworks and the sub-frameworks that are nested within the book. So every single chapter gives an overview of ways that one can think about topics like governance arrangements, issues like care by sector, and then it applies that thinking, of course, to Ontario, but it's available to anyone in any system to make use of that and then to apply it to their own system. So I think from the perspective of people in other systems perspective, we hope the book is going to be valuable for the many frameworks and sub-frameworks that help you think systematically through how a given health system is organized. A second advantage that we think other systems can benefit from are our Sector 4P figures. So I'm not expecting you to be able to read the fine print on this figure, but it's a screen capture of our Sector 4P figures. So imagine that you've opened a book and you have the center with the binding in the middle. This Sector 4P figure would be spanning 2 pages. And the 3 columns to the left of the binding in the middle, on the left, and the 2 on the right capture 5 of the 6 sectors that I've spoken about before. So home and community care, primary care, specialty care, long-term care, public health. Rehab is not there as a separate sector because we see it embedded in these other sectors. The first column is technology provision. Things that we do in order to provide drugs, assistive devices, and so on to people. And the last column is the federal category, because everything else, the focus is on provinces. So these columns allow you to describe for a particular sector, for a particular condition, for a particular treatment, for a particular population, what is happening in each of those sectors, or for technology or at the federal government level. And then the rows, which you'll see itemized on both the left and the right-hand side, are policies, programs, places, and people. And so what we do are, for any given area, tell you, here are the policies you need to know about, here are the programs you need to know, here are the places where people receive care, and here are the people that are involved in either providing that care or who are recipients of that care. So I've shown you by far the most complicated one. This is the overview of our entire health system. If you're looking at the figure specific to primary care or for prescription drugs or for Indigenous peoples, it's much more simplified. So I've shown you the most complicated so you can get a sense of just how many policies and programs, how many places, how many people are involved in our health system. So something else that people in another health system could easily take the blank version of this and quickly map in what people need to know for their system about a particular sector treatment, a sector condition, treatment, or population. Third thing that people in other systems might want to know is how to access similar descriptions to the one that we've prepared for Ontario, so phone system. All of these types of health system profiles are available through our database called Health Systems Evidence. And if you haven't accessed it for this reason before, if you just go to the URL that I provide here, click on Advanced Search, pick document type as health system descriptions, and then type in your country of interest. So you could type in, I saw Mario on the list. Mario, I blanked out if you're from Panama or Costa Rica, but you could type in your home country. If you're from Nunavut, you could type in Nunavut. If you want to see the profile for Canada as a whole, you can type that in. And as soon as the book and the chapters are freely available, you'll be able to type in Ontario and always find the most recent version of the material. So we continuously update this. Anytime a new health system profile comes available for any Canadian province or any country around the world, we would add it to health systems evidence, so you always know where to find the most recent version. And that's it for my top 10. So over to you, Steve.
Yes, well, thanks very much, John, for those insights into quite a broad range of elements of Ontario's health systems, and certainly how that can apply to health systems beyond Ontario as well. I'm just going to open up a quick poll to get everybody's feedback on if there was any particular areas that were of special interest, or the insights were of special interest to you. But Vasanthi, if you would also like to share your feedback and comments on John's insights, that would be great.
Absolutely. I'll wait for the others to comment.
Well, looks like a pretty broad range of interest there, with the care by sector certainly getting quite a bit of interest.
And if I can just speak to that one, you know, the other health system descriptions that exist for other Canadian provinces or other countries don't really go into a lot of detail on care by sector, and often, and certainly for care for select conditions and so on. So I think one of the things we've tried to do is to really help people understand the system in areas that they care about. So how does the primary care part of the system work? How does care for mental health and addictions work? What is it? What's happening in the area of prescription drugs, and what's available to people that is publicly covered? So that's, I think, maybe the biggest differentiator from any other existing book on the system, is that concerted effort to explain how the system works in tangible ways, by sector, by condition, by treatment, and in the case of one population, for Indigenous peoples.
Okay, so I've just closed that poll, but so Vasanthi, if you'd like to share your insights and your comments on what John talked about.
Yes, first of all, John, congratulations. I don't know of a comprehensive text on the Ontario health system that anybody has dared to pen, because we all believed at one point it was not a system. We had to work towards it. And we have, as you acknowledge. But I don't think there's a comprehensive place where we can go and get such a wealth of information. So congratulations to you and your team. It's absolutely an onboarding tool for anybody in the sector, in the system, as well as in government. I think it's just superb. So one thing I'd like to add, and maybe it's in the full text, is the role of the politicians, because that's key to understanding how the agenda moves forward or doesn't. Because we do have political masters. You mentioned how much progress we've made since 2003. Clearly, it was a milestone in our political history. We moved towards a Liberal government that came in with a lot of ideas, and in very quick succession put these ideas into practice through acts, etc. So I don't want to underrate the political influence on the system as we've outlined it here. The next thing that I thought I would talk about is how does evidence get articulated, and how does evidence get pushed to government where decisions are made, or to the LHINs, etc., or the sub-LHINs as they've come into focus with Bill 41. So we don't put enough emphasis. We do our best on evidence generation and people like you, John, have held us for all these years moving forward, but I'm sure you won't disagree that to make a more sizable investment in evidence generation is becoming more and more critical, because one reason, the health accord is going to come into focus very soon, and our colleagues might be monitoring those discussions. This is the accord the provinces and territories will be signing with the federal government for transfer payments, which come to the Department of Finance, not Health. I'll talk more about that later. But as this is getting prepared, as we're feeling out how the federal government, who has a fiduciary right on all these issues, but the delivery side is delegated by Constitution, by the Charter, to and the Canada Health Act, to provinces, figures, because we're going to come down from 6% to 2%. It's a major drop in revenues coming from the feds, which altogether promised in the beginning 50% of our health spend. That's where the Canada Health Act started. We're now down to about anywhere between 24 and 26, and it's further coming down. So how will the provinces manage with an aging population, where the demand is increasingly getting higher, and with the revenues going down, is going to be a serious point of debate, point of discussion with the feds. So, and the lead up to all of this is done through the federal, provincial, territorial committee work, where all the heads of health departments, the ministers, etc., have conversations. But all of that has to gel in the health accord, which can go anywhere from 3 to 5 to the last one was 10 years. So that's a big contextual piece that we have to think about. I love your 10 important, 10 could become 20, it could become 25 quite readily. But it's a wonderful way to be able to explain to people how the various sectors play into this big puzzle, and what are the pieces that they take away from the puzzle. The thrust of the Ontario government for the last 10 years or so has been to move as much of the health care into home and community. Easier said than done, but that's where the tension has been, to try to avoid excess days in acute care centers where the cost is necessarily higher, and bring it down all the way to home and community, which includes the palliative care piece, where we spend inordinate amounts of dollars, not to the satisfaction of patients, but and that's how the system is able to cope with the pressures of palliation. I lead the Ontario Sport Support Unit, which is a new creation, relatively. It's about 3 years old, where we're trying to do patient-oriented research, the kind of research patients want, patients' insights, experience, become very valuable and are integrated by researchers in producing the final analysis. So I think we're on the right path, but everything is not going to come together overnight. So we will need to focus on priority areas, as you know, for our Indigenous populations. Mental health, diabetes, etc., are very important. In the governance mechanism, we need to have a tighter, more focused regional health authorities. In the case of Ontario, you call them the LINs, and the sub-authorities to deliver the services. But it's a question, it's like an orchestra. We need to bring everybody together to start performing the symphony in a manner that's interesting to listen to and obviously serving the purpose. In all of this, also the health human resource component is very critical because it's people that make the system, and the variety of, I don't mean only doctors or nurses, but the variety of healthcare professionals, how they're incentivized, how they're motivated, what is expected of them, what are they willing to take on, will all become areas for discussion. And I think it's in the cohesion of the system that we're going to make it stronger and evolve at a better pace than perhaps it has up to now. I'll stop there.
Much, Vasanthi. Just a couple of quick reactions. Thanks for the kind words, but especially the thoughtful observations. You've hit a lot of very important points. Just a couple of quick things on the role of politicians. We do cover it in the governance arrangements piece in terms of the role of the minister, cabinet, the legislature, and so on in making decisions, and also in the reforms chapter where we talk about, politicians need to be convinced there's a problem and a set of causes that are amenable to action. They need to be convinced they have viable policies, and then the politics need to be right. And obviously those three things need to come together when we're going to have big reforms. We also talk about the book that we wrote on healthcare reform across Canada, where we learned that the big reforms in our country typically come about where there's a newly elected government or a newly elected leader of a governing party and a fiscal crisis. And so arguably, after our next election, if the fiscal situation continues as it is, and a new government comes in or a new leader comes in, that might be the conditions that are needed in order to have a more fulsome reform. Third comment just has to do with your comment about the evidence. Made me remember to say that all of the key documents that we cite in the book are also going to be available through Health Systems Evidence, so it will be a very easy way for people to find material. Second to last comment is your comment about the Accord and the federal government just reminded me how limited coverage we ended up giving the federal government, except for areas like prescription drugs in this book, because the previous accords are now over. There's no new accord, and so they're not playing and haven't played for some time a very prominent role, but that could end up changing depending on which way the accord goes. And the final point about the Ontario Support Unit, we have a section on citizen and stakeholder engagement in the system, and while OSSU is focused on their engagement in research, it's also catalyzing citizens and patients' engagement in driving change in the system, which I think is really critical and something that we give some coverage to. So thank you for those comments. Steve, should we open it up to other comments?
Yeah, absolutely. I think this would be a great time to open it up for questions and answers. So if anybody has any questions for either John or Vasanthi or both, I would encourage you to use the chat box in the bottom right-hand corner of the screen to ask your questions, and then we'll progress through those as they come in. As we're just waiting for a few questions to come in, I'd just like to highlight that we're currently planning our webinar series for 2017. So I would just encourage everybody to go to the McMaster Health Forum site. We have a page there for our top 10 webinars where we'll post all the information for those webinars once we have them confirmed. But again, we'll be doing some more webinars focused on specific chapters of this book, as well as topic-specific webinars, and also looking at a little bit more of a global perspective with some of our partners around the world as well. So it'll be a variety of different topics getting covered. And again, I would encourage you to check out our website and the Top 10 webinar page, or certainly follow us on Twitter and using the hashtag MHF Top 10, because we'll highlight all the information there as well. So, well, while we're waiting for questions, is there any other points that either John or Vasanthi would like to highlight, or?
Yes, one quick observation from me is that I thought I knew the Ontario health system very, very, very well from all of the work that we've done here at the forum, from having studied it for years, from having worked in it. But it was a revelation to me about just how big and complex it is, how many policies, programs, people, places. I mean, it's when you think about how complex it is, and how and it's touching on the lives of so many Ontarians. It was a real wake-up call for me about the system, and as I flagged and Vasanthi reiterated, how many tangible steps have been made in the last 15 years to iteratively move us to a more integrated system. So we know,
and that's always the mission of government, is integrated systems, but it's easier to talk about it than actually do it.
Yep, absolutely.
So Don asked, how have shifts in power, person-centered engagement and paradigms, evidence, cost containment, worked to drive transformation in other jurisdictions?
So Don, the only thing that I can speak to that's empirically based as opposed to anecdotal would be our effort to study healthcare reform in 5 of the big Canadian provinces. We looked at 6 cases, same cases, although of course they played out very differently in the 5 jurisdictions, so 30 cases in total. The things that you mention don't come up front and center. As I mentioned before, the 2 factors that seem to explain the bigger reforms and the frequency of those bigger reforms had to do with the combination of politicians being elected with a mandate to bring about changes in the system, whether that be as a new governing party or as a new leader to a party, and the other thing being a fiscal crisis. Now, of course, power is always very important. Ideas, as embodied in paradigms and so on, are obviously critical. But having looked across a number of variables in those 30 cases in Canada, what seems to make a really big difference is that political drive backed up by an election coupled with the fiscal crisis. That is the only pair of factors that emerged with any consistency in the biggest study that's ever been done of healthcare reform in Canada. I'm not familiar with cross case analyses that use comparable methods for other jurisdictions to be able to comment on what would be the finding in other countries. But that's what we've learned from the Canadian study. Vasanthi, do you have anything to add?
In one word, this is a very dynamic piece. There's no element of it that is static. So it's moving with the political parties, their persuasions, the economy. I'm just thinking of Alberta now. They've gone through major system reform in the last 5 years. But guess what? They're still going through it because the orientation of the Notley government is a little different from what the Tories for years had. But more than that, it's the economic reality in the province that's shifting things. So never to assume that the health system has all been constructed, put in place, and we can just enjoy it from afar. Because every day, I know in the Ontario ministry where I was, as well as other ministries, there's constant evolution on issues. You're never done. And the paradigms are never fixed, because when you've done one, you're looking for the other spot where there's trouble. Ontario is going towards a balanced budget in March. You can only imagine what the budget talks are like in the Ministry of Health and them with Treasury Board, because there's very little to no room per movement. So that creates a real friction between Ministry of Health and the Ministry of Finance. All of it justified.
Great. Thanks, John and Vasanthi. We have another question from Harry. He's said that Donald Trump has claimed that the Canadian healthcare system is very flawed, which is why many Canadians go to the US for healthcare to avoid long wait times, etc. Do you think his claim is true? How do you think we can improve on that problem? And could you please briefly compare our healthcare system with that of the States? Thank you. So,
Do they have a system?
Field that first?
Right. So I guess a couple of comments. So, one is, I guess you always have to ask what could be the motivation for people making comments about whether one system performs better than the others. So there is a very large lobby group in the United States represented by insurers and a number of service providers that would not like to see the Canadian system be shown to perform better than the US because they're advantaged by the current US health system arrangements. So you always have to be skeptical about people that are making assertions without being able to back up their statements. On the issue about people going to the US, the last time that this issue was systematically studied, at a time when there were statements being made about huge volumes of Canadians going to the US, the finding was that the numbers were exceptionally low. So this was work led by people at the UBC Centre for Health Services and Policy Research. So we don't have very good evidence that large numbers of Canadians are going to the US for care. When it comes to outcomes, the last systematic review, and the only systematic review that I know that has compared the outcomes of the two health systems, was not able to show that one system performed better than the others. And of course, it's very, very hard to assess two health systems objectively in ways that are easily defended. But nevertheless, that systematic review showed a number of efforts, no indication that one clearly outperformed the others. Then when you come to triple aim, I don't think anyone would argue that the United States is keeping per capita costs manageable. In fact, per capita costs there are the highest in the world and continuing to rise. Ours are quite dramatically lower. In terms of improving population health, I don't know that anyone would argue that the United States is achieving better outcomes. But of course, outcomes are a mix of the impacts of the health system and the determinants of health. What you're seeing there is partly the differential exposure to these social determinants of health, and partly the way that the health system works and helps the better off and doesn't help the less well off. The area where I think that we can learn a lot from in the US is improving the patient experience. And I think that there are deals with patient experience that offer lots of opportunity for us to learn how to do better. So again, I'll sum up by saying I don't think we have strong evidence to back up Mr. Trump's assertions, but that doesn't mean that, at least in the area of improving the patient experience, that there aren't very powerful insights that we can glean by studying our neighbors to the south.
Absolutely. And I think it was Bernie Sanders that brought up the single payer system. Ours, we call it a single payer system, but there are, again, there's complexity because there are private insurers involved, etc. Well, I wouldn't go with anything Mr. Trump casts accusations, but I know there's, John, you're perfectly right. There aren't the kind of flows to the south. In fact, the ministry, we pre-approve certain procedures that's still happening today for people to go to the south of the border.
Yeah, absolutely.
And that's considered, critical interventions for which we don't have capacity, or don't have capacity near to where the patient is, so we send them south. So that happens.
Absolutely.
And that is going to happen, and I think that's wonderful. But I don't think there's a big number of people saying I'm going to the States, because the costs in the US, if you look at it very carefully, are prohibitive.
And especially, what we sometimes forget is that, the costs that we typically, or the prices that we typically see in the US are typically the negotiated price that an insurer or a large integrated delivery system has negotiated. When one tries to purchase a service
Yeah,
in the US without any bargaining power, then the price can be absolutely astronomical.
whatever.
So that would, yeah, and that's probably one of the many reasons why we don't see a lot of the movement south. So
Hmm.
Steve, I think we're out of time. I'll leave it to you to
Yep.
wrap up.
Yep. Thanks very much. Yeah, I just wanted to say a quick thank you to John and Vasanthi again for taking part in the webinar today. It was a very interesting discussion and some great points raised by both of them. And I also wanted to thank everybody for joining us here. Again, just a quick reminder that we will be doing more of these webinars next year. So please come to the McMaster Health Forum site to check out our schedule, and we hope that you'll join us for future ones.